Hello everyone, I'm Jana van den Broek. I'm a transfusion practitioner from Belgium. In our next two podcasts, we will be talking about the non-medical authorization of blood. What that phrase means is that the decision to transfuse the patient is made by a non-medical practitioner, usually a registered nurse or nurse practitioner. And the nurse then makes the order for the blood component to be issued by the laboratory and to be transfused to the patient. We use the term authorization. However, we know different countries have different terminology for the process of making the decision to transfuse and issuing the blood order. In this first podcast, we are going to ask 3 members of the ISBT transfusion practitioner subgroup about what happens in their countries, Australia, Canada, and the United Kingdom. We know that non-medical authorization is not undertaken in all countries, including Belgium, where I am based, so it will be interesting to hear about their processes. In our next episode, where we will talk with some nurses who undertake non-medical authorization of blood. If you are not sure what transfusion practitioners are, you may want to go back and listen to our first podcast about what is a transfusion practitioner. We are very fortunate to be able to bring you this podcast thanks to the support from the International Society of Blood Transfusion, known as ISBT. ISBT is a global community of professionals sharing knowledge to enhance transfusion practice and blood management. The society does this by providing opportunities for advancing knowledge and education and by advocacy for the welfare of blood donors and patients. ISBT has many working groups that focus on specific topics or areas of practice, and one of those is a transfusion practitioner subgroup. So now we are going to meet our guests for today. Lily, can you please introduce yourself and which country you are representing?
Hello everyone, I'm Lindley Bilby and I manage a program called Blood Matters in Victoria, Australia. The program supports best practice in patient blood management and the stewardship of blood. I also have the privilege of chairing the ISBT Transfusion Practitioner Subgroup. Thanks, Jana.
Thank you. And then we have Claire.
Hi, my name is Claire O'Reilly. I am the Transfusion Safety Nurse Clinician for British Columbia Children's and Women's Hospitals.
And last but not least, we have Rachel.
Thanks, Jana. My name is Rachel Moss. I am a transfusion practitioner of some 20 years now, probably one of the oldest in the United Kingdom. And I currently work at Great Ormond Street Hospital, which is for children in London.
Thank you. I am very glad to have you all. So for how long have nurses authorized blood in your country? Lily?
In Australia, we tend to not use the term non-medical authorization, and we primarily have 2 processes for prescribing blood components for nurses. One is where the nurse can act on a medical standing order, and the standing orders are most commonly in place for the use of RHD immunoglobulin or anti-D. But there are also some in place for specific patient groups that require blood transfusions on a regular basis. The other process is nurse practitioners. And a nurse practitioner is a nurse that's undertaken additional education to provide advanced practice within their specialty area of practice. This role may vary slightly across and between countries. In Australia, after specific education, blood components or products are listed on the nurse practitioner's individual practice portfolio, and so they then are authorised to prescribe those. As with many things in Australia, there's diversity across and within each of the states and territories. As nurse practitioner roles are relatively new, I think the first one of these would have been able to prescribe about 6 years ago, and more are doing so now as the numbers of nurse practitioners increase. Where standing orders are in place, many of these have been in place for years. Our Society of Transfusion, called the Australian and New Zealand Society of Blood Transfusion, has established specific guidelines for the prescription of blood and blood components for nurse practitioners, and these are available on their website.
And Claire, how is it in Canada?
Yes, nurse practitioners for whom blood and blood product authorization is within scope of practice were legally recognized in British Columbia, Canada in 2005. Nurse practitioners in BC have been prescribing blood and blood products since 2010. And prior to 2005, prescribing of rhesus immune globulin was within scope of practice for registered midwives within BC. Across Canada, authorization of transfusion is within scope of practice for nurse practitioners. Over to you, Rachel.
Thanks, Claire. So it's interesting because nurses have actually been ordering blood informally for many years in the UK. So many hospitals have electronic ordering systems, but before that, they might just write the blood order and then that would go down to the laboratory to issue. Or they would write blood order on a patient's chart, at what we would call a prescription chart, and then ask the doctor to sign the order. So it was happening in a very informal way. But it was about 15 years ago that we really started to formalize this process. And that's when this term, non-medical authorization, came from, really because we knew it was happening. And then we formalized it. And we're going to talk about that as we go through our podcast.
Okay, I was wondering if there was a trigger for it becoming something nurses could do, or did it just happen organically?
In Australia, as the nurse practitioner role started emerging, prescribing for their specific patient group seemed just to be a natural progression towards holistic care for the patient. The increased numbers of nurse practitioners requesting a process for education to include the prescription of blood and blood products led to the development of the Australian and New Zealand Society of Blood Transfusion Guidelines that I previously mentioned. Standing orders for RHD was also about holistic care and was deemed to be part of the registered midwife's scope of practice. And standing orders for blood components in specific clinical cohorts was also to support patient efficiencies for patients, nursing and medical staff. Thanks, Claire.
Yes, including authorization of transfusion in the scope of practice for nurse practitioners opened the door for individual nurse practitioners to decide to pursue the option and complete relevant education and begin ordering transfusions within BC and across Canada. And Rachel?
So we had a paper actually that was written in 2007 by Liz Pirrie and Jan Green. And these were, I think, well, certainly one's retired and maybe both have now. Two nurses were working in the UK blood services. And as I've just said, they knew this was happening. So they outlined a paper about the fact that nurses needed the education and they needed a formal framework so that this could become something they did as part of their role and not just as an ad hoc basis. And this really triggered what we might call an extended role, although that's an older term now, but the role over and above what most nurses would do on a day-to-day basis. So that was the trigger, and then it's just taken from there.
That's a nice evolution. What sort of nursing roles authorize blood?
In Australia, the nurse practitioner roles are in areas where blood and blood products are commonly used, such as in oncology, haematology, renal, immunology, inpatient blood management, and for midwife nurse practitioners. There is also a mix across adult and paediatric services in Australia. For the RHD, this could be a midwife nurse practitioner where they can prescribe and administer, or it could be midwives or emergency department registered nurses where there is a medical standing order. Where blood components standing orders are in place, these are usually in day areas for those chronically transfused patients. Claire?
Yes. As I've stated previously, authorization for transfusion is within the scope of practice for nurse practitioners, and really depends on their area of practice whether or not they will decide to pursue authorization of transfusion. So usually in oncology, hematology, emergency departments, cardiology, orthopedics, and similar areas. And then for registered midwives, they can be practicing within a healthcare facility or independently. Rachel?
So I think in the beginning, and certainly Jan Green was a hematology nurse. So it was really seen, as we've all sort of said, hematology, oncology would be the biggest areas. And actually, that does make sense because these patients, as we said, are transfused frequently. And that could be a red cell or a platelet. But I think what's interesting that's now happened over the last 15 years, as it's really mushroomed. So we've now got nurses coming through from the neonatal intensive care units, adult intensive care. We've got cardiac surgical units, including ECMO, so extracorporeal membrane oxygenation, both in children and in adults. Renal dialysis nurses, emergency department nurses, and certainly at my institution, our retrieval nurses, so they're the nurses that go and retrieve the patients and bring them back to our centre. They also have undergone training to transfuse. So it's now becoming so much more than just oncology and hematology as it was in the beginning.
Interesting. And I was wondering if there is a specific training program.
Thanks, Jana. Yeah, in Australia, the nurse practitioners must undertake a formal nurse practitioner masters for their basic nurse practitioner qualification. And then they undertake additional education and training to include blood component therapies. And this can be quite varied, the type of education they have between in-house training with medical staff, or it could be online training. In line with the Australian and New Zealand Society of Blood Transfusion guidelines, sites that are required to endorse the nurse practitioners' practice portfolios and also their training and the monitoring. And this should be done by the blood management committee within each one of those health services where the nurse practitioner works. The guidelines recommend that the training should be predefined and it should include the decision to transfuse, it should include consent, compatibility, products, dosing and rates, along with adverse event management and hemovigilance. And for RHD, many of the Australians go to the Australian Blood Safe e-learning RHD module. So handing to you, Claire.
Yes, education, training and competency assessment varies by province. However, all practice must adhere with the Canadian Standards Association and Canadian Society for Transfusion Medicine transfusion practice standards. In BC, nurse practitioners complete the Ontario Blood Coordinating Office's Bloody Easy education modules, and they also attend the multi-day BC Nurse Practitioner Transfusion Boot Camp. And the modules within this boot camp are blood component indications and administration, complications, compatibility, acute and long-term transfusion risks and errors, and acute special transfusion situations. There is a mix of didactic lectures followed by small group modified team-based learning seminars led by a physician transfusion medicine expert. And we will provide a link to an article about the boot camp on our webpage. And the article is called Educating the Next Frontier of Transfusionists, a transfusion camp pilot program for nurse practitioners in Transfusion 2020. Thanks.
Thanks, Claire. So in the beginning, after we all realised that nurses were going to authorise blood, there was lots of local causes, particularly within areas or even within hospitals. But it was quite obvious that both content and quality was extremely variable. And Claire and Lindley have spoken about some of the things they do. So there was no guarantee that these things were happening. So this has now been picked up by the NHSBT. So that's the National Health Service Blood and Transplant Service, who oversee all our transfusion services, particularly in England. And they used to do a 4-day face-to-face, and they would bring in experts from all over the UK to talk to the delegates. Now we do it online. We still bring in experts from all over the UK. And what that means is that we can have that level of quality of speaker, including me, but we'll gloss over that. But things like the shot level and people of that caliber, PBM practitioners, and all our nurses and midwives that come through are usually working at a clinical nurse specialist, advanced nurse practitioner level. So there's an almost like an M level expectation of the level that we teach at.
Good to know that there is a very well organized training everywhere. And do the nurses who authorize blood get any supervision or mentorship from a medical colleague?
Yes, Jana, in Australia, the nurse practitioners have oversight of their clinical practice. They also are supervised and mentored. The supervision of the nurse practitioner is from their supervising medical officer, and often they will have mentoring from other more senior nurse practitioners. Blood management committees should also act as a resource for all of the practitioners, including nurse practitioners, to provide them with the clinical guidance and governance that they need within their role. And actioning standing orders is usually by senior experienced staff as well, and they will often mentor juniors coming through, so we've got a succession plan in those clinical areas. So now to you, Claire.
Thanks, Lindy. So I supervised the Canadian Society of Transfusion Medicine Transfusion Safety Network members, who include laboratory staff, physicians, and RNs, asking them these questions about nurse practitioner authorization for transfusion. And one respondent stated that nurse practitioner graduates are supervised, but didn't state for how long. And I'm not sure if a nurse practitioner would use the word supervision here in Canada because they're autonomous practitioners. Nurse practitioners are autonomous practitioners, and they work as part of multidisciplinary teams, and they have best practice support from medical colleagues, but they're not supervised, but there will be oversight from the transfusion committee within the institution where they work. And
Thanks,
Lindley,
Claire.
sorry.
Oh, so to me now. So the decision is not taken lightly, I think, by the nurse, because there's a lot of responsibility, and it's done in conjunction with their clinical specialty. So that's their supervisor, their line manager, and the consultant who oversees that clinical area. And then once they've had their training and they've gone through the theory that I've already alluded to, that NHSBT provide, then the senior doctor who they nominate and who agrees to be their supervisor, they oversee the prescription, the authorization, whatever we call it, of the blood. And it's once that has been done in the clinical area that the nurse is then signed off. So the theory, then the practical under supervision from a doctor, and then they're free to go.
Okay, and what benefit do you think the non-medical authorization or prescription of blood makes to the patient's care?
Well, Jana, the unanimous benefit that's been reported to me is the improved patient care, as there's continuity of care from the same person. The nurse practitioner and the clinic nurses and the midwives are the ones that are regularly seeing these patients throughout their whole health journey, whereas the registrars and interns rotate very regularly. So nurse practitioners undertake a full patient assessment, and when treatment is required, it is given in a much more timely way, and they don't have to wait for medical staff to actually attend and write up orders. So over to you, Claire.
Thanks, Lindy. So as I said, I surveyed the Transfusion Safety Network members, and I'll share some of the responses. Nurse practitioner authorization of blood may help alleviate a physician's workload. The nurse practitioner ordering expedites the transfusion, and in some cases coordinates other aspects of the patient's care. And that goes back to what Lily was sharing about the holistic approach. It allows care in remote areas where patients may not have availability for treatment. Canada is a very large country, and we have many small and remote hospitals, and having nurse practitioners work in these hospitals, authorized transfusion really enhances the care of the local population. In our setting, I see this as beneficial. Patients coming in for their weekly checks and transfusions can easily be managed by a nurse practitioner, allowing the oncologist to focus on other aspects of patients' care. That's another respondent's response. Helps with the global healthcare professional shortage, definitely very relevant in current times. Nurse practitioners are more connected with patients and their progress as they're generally more frontline than physicians. And another respondent shared that nurse practitioners have more practical experience with transfusions depending on their previous areas of work and education. Like they may have been, as their role as registered nurse, being administering blood components and products. My personal opinion is that in situations where nurse practitioners manage most aspects of a patient's care, it makes sense that the nurse practitioner would also be involved in ordering their transfusions. Most nurse practitioners will have more practical transfusion experience, administering blood, following up on transfusion reaction, etc. So, Rachel, I'm intrigued to hear what you have to share.
And probably exactly the same as you, Lindley, because it just, and as we're nurses on the group, we're very passionate about our nursing role, but these are advanced nurse practitioners, highly skilled clinical nurse specialists. And these nurses have been working with many years' experience, particularly with their own patient group. They know their patients, they work closely with them, they often prescribe blood, a lot of the drugs even. A lot of these nurses have their own patient load, they prescribe the drugs that they might need, they can order the blood tests, they can do full patient assessments. Many have done further training to be able to do these clinical assessments. And so blood transfusion ordering authorization just seems like the next step, because they are being made by somebody who knows the patient. And as Lindley said, the transience of doctors moving from specialty to specialty or location to location, the nurses are one constant. So there's that greater continuity that I think patients like, because they know the person making those decisions understands them and their health needs.
Okay, thank you. Now that we have talked about the benefits, do you think there are any risks associated with nurses authorizing blood, Lindley?
Well, thanks, Jana. The decision to transfuse is not without risk for any prescriber. And those trained nurse practitioners are no more risk than the medical staff ordering. In fact, the nurse practitioners prescribing and administration practice in Australia is actually audited very regularly. So you might say that given that there is the requirement for their regular monitoring of practice, it may actually be reduced because of any of the deviation would be picked up early and addressed. Whereas in the case of a medical officer's ordering, this might not be the same. So depending on each health service, the requirement for updating education varies. So I guess that might also be considered a risk, making sure that they keep up to date. So now, Claire, let's hear about what happens in Canada.
Thanks, Lindley. So I'll share some responses to the survey I conducted with the Transfusion Safety Network, which I said are a mix of nurses, laboratory staff, and physicians. One respondent said many risks, but they didn't list. Another respondent shared they not necessarily a risk, but depending on the nurse practitioner's role within the healthcare team, if ordering blood components and products isn't normally a function of the nurse practitioner, they may face barriers or confusion from the transfusion medicine lab, who are more used to seeing physicians ordering. So it's interesting to get that perspective from lab personnel. When education is not in place or institutional policies are not in place, that would be similar for physicians and nurse practitioners. If nurse authorization or an ordering for a broad general patient population, nursing knowledge and critical thinking skills would need to be assessed. So I guess that's depending in the areas that the nurse practitioner is ordering, and normally nurse practitioners are working as part of a team with a focus in one area. Nursing in Canada is a self-regulated profession, and in BC, the BC Colleges of Nurses and Midwives set standards to ensure nurses provide safe, competent, and ethical care. The college will intervene when nurses or nurse practitioners do not meet these standards. The risks associated with nurse practitioner authorization of transfusion are similar to physician authorization of transfusion. Inadequate education, failure to follow best practices are risk factors. The risk lies with the individual practice rather than the professional designation. I don't think that nurse authorization of transfusion automatically means an increased risk for the patient.
Yeah, I think they're excellent points, and I'm probably just reiterating a very similar thing. I think every risk, as we said, every transfusion has a risk, whoever authorizes it. But I do believe that because we train nurses and give them this extra training, the boot camp that Claire mentioned, and they work within their own sphere of practice, that they are closely supervised and probably make decisions with a lot more thought, personally, I think. And certainly in my organisation, I will do 3 yearly updates with every nurse that authorises blood outside that is not a doctor. I mean, the irony that we don't do this with doctors is not lost on any of us, but that's probably a discussion for another podcast. So I do think that a doctor can qualify and be making decisions to transfuse with the patients within days. With nurses, they are so well trained that by the time they get to make those decisions, I think that the knowledge we give them far exceeds what perhaps some of them or medical colleagues might get. So therefore, I agree. I don't think there are any huge risks.
Okay. We have learned a lot already on non-medical authorization of blood components. Is there anything else about it that you would like to mention?
Well, from, I guess, our perspective and my personal perspective is that I think it's a really patient-centered approach, that it improves the continuity of care for the patient and also the timeliness of their care. And patients also report that they think it's great, so they provide positive feedback. I guess one area where there might be some scope practice is sometimes if they're being pressured, if a nurse practitioner might be pressured by their colleagues in a busy clinic and need to get consent before they can start transfusion, or perhaps need an order and the doctor's being held up. So there might be a potential for scope practice. So I guess that's one area that we need to be mindful of, and I guess would come up in the nurse practitioner's process of audit if that was happening in practice. So I just think it's a great role.
Yes,
yes, Claire, sorry.
I'm very supportive of nurse practitioner authorization of transfusion. I think institutions should have robust electronic order entry systems or pre-printed orders that support and even force best practices for ordering blood and blood components. All processes for authorization of transfusion should be monitored and audited so that poor practices can be identified and addressed. Nurse authorization of transfusion enhances patient care, provided that the nurse practitioner adheres to transfusion standards related to education, competency, and practice, and their nursing college standards. Nurse practitioner authorization of transfusion does not impose an increased risk to patient safety and offers many benefits.
Thanks, Claire. I think I'd just finish by saying that every nurse that undertakes this role does so after much thought. They think about what it means to them and their professional registration, the benefit it brings to the patients, what it means to their clinical service, the scope of practice. It is not entered into lightly, but with good theoretical training, clear guidance from the teams and within their own scope, and we've talked at length about the nurses taking responsibility for the actions, I think it makes a really, really positive difference to the patients they look after.
Thank you all for sharing your time and experiences with us. As I said at the start, many countries do not have a non-medical authorization of blood components. Establishing this as a regional or national program takes a great deal of time and commitment from those involved. But for anyone who thinks there are many benefits for nurses and patients to do this, then there are resources, including templates for policies and competencies available on the internet. Thanks so much to the listeners for joining us today. If you have any feedback, please use the questions linked with the podcast. If you have further questions, you can link in with us by visiting the ISBT website and checking out the Clinical Transfusion Working Party, where you will find more details about the Transfusion Practitioners subgroup. We look forward to having you join us for our next episode, where we will talk with some nurses who undertake non-medical authorization of blood and how they think it improves transfusion care for their patients.